Yeah, please start now.
Okay, so good. Yeah, good evening, everyone. So continuing decoding GI-HPB oncology and continuing the webisode on pancreatic and periampullary cancer. So today we will be discussing the metastatic and unresectable pancreatic and periampullary cancer. So format will be same lecture followed by the panel discussion, case-based. So I invite Dr. Manish Singhal, who is from Apollo, who is a senior consultant medical oncology. So he will be delivering lecture on unresectable and metastatic pancreatic and periampullary cancer. Dr. Singhal, please.
Thank you, Shifali. I think it's a very nice initiative that you have taken. Now that's the problem. I don't know. Once again. So, sorry. How do I go about it?
Are you able to share your screen?
नहीं, वही तो नहीं हो पा रहा.
Share screen.
Share screen पे
मनीष, कोविड ने कुछ नहीं सिखाया आपको.
यार अब पता नहीं क्या नया चक्कर हो गया, मुझे समझ में नहीं आ रहा.
ये दो चीजें ही सीखनी होती है बस कोविड.
But I don't know why am I not. नहीं, share screen का ऑप्शन तो आ गया, but उसमें it is not showing up.
आपने ओपन किया हुआ है? आपने पीपीटी ओपन किया हुआ है अपने स्क्रीन पे?
अब कर लिया, yes.
हाँ, so now it is visible. Yes.
Now it is visible.
Yeah.
And is it moving also?
No, you do it full screen. अभी तो slides share वो है आपका.
Slide show mode.
यही वाला करना पड़ेगा.
Slide show mode पे करो.
Because वो full screen करने के बाद move नहीं कर रही है slides.
अच्छा, कोई बात नहीं. This is also visible. Yeah, it is moving now. It is visible. Yes.
So very quickly, I'll talk about the theoretical part of it, and this is evidence-based management of metastatic pancreatic and periampullary carcinomas. And since we are talking of metastatic, we mean that those which are unresectable and those which have generally they have spread to the liver. So we know that pancreatic cancer syndromes they generally present with asthenia, weight loss, anorexia, abdominal pain, dark urine, sometimes jaundice, and nausea, backache, diarrhea, vomiting. So this is the pancreatic cancer symptom burden, which usually is the main cause or the main presentation of these patients. And cigarette smoking, chronic pancreatitis, and obesity are certain modifiable risk factors for having pancreatic cancer. And now we also realize that there are certain genetic syndromes, and even knowing the genetic profile of the patient has become so very important in not only diagnosing, in perhaps in prevention, and also in treatment of pancreatic cancer. If you look at the spectrum, if there are 100 cases of pancreatic cancer which come to us, almost about maybe around 20% are surgically explorable, and they can undergo a resection, be it via R0 or R1 resection. R1 resections are not very uncommon in pancreas because it's a retroperitoneal structure, and taking a retropancreatic margin becomes difficult. About 35 are locally advanced and unresectable upfront, but they may become resectable with neoadjuvant chemotherapies. And but the vast majority of patients come with metastatic disease, and some of them, about 10%, are not even eligible for any type of treatment. As far as therapies are concerned, there used to be hardly any therapy till quite some years, and gemcitabine was the first therapy to be to show a survival benefit and to show quality of life benefit. And it was in 2005 or 6 that erlotinib came in, and after that there has been some development with newer drugs coming in, such as FOLFIRINOX and the combination with nab-Paclitaxel. And very lately there is the liposomal irinotecan, which is not readily available, but that is one treatment option which is there. So if you look at the incremental benefits with new agents of treatment, the survival, the median overall survival, the ballpark figure has been less than 6 months with gemcitabine alone. As a matter of fact, the Bures et al. Study, which was the first study of gemcitabine, actually did not have overall survival as the primary endpoint. The primary endpoint of that particular study was pain control, improvement in performance status, and weight gain. So that was the primary endpoint of the study and not median overall survival, because they were not really looking at an overall survival gain. And the comparison between gemcitabine and 5-FU led to the theory that gemcitabine perhaps actually increases survival as compared to 5-FU, and therefore gemcitabine became a standard of care as a single agent. As far as gemcitabine plus erlotinib is concerned, there was a very small, very marginal gain with the addition of erlotinib, and generally the erlotinib was given in this particular study at 100 milligram per day. But people were not very amused by the addition of this particular agent, because the median survival gain was about 15 days to 20 days, and that's what it was, although it was statistically significant. Finally, we had the PRODIGE data, which is the FOLFIRINOX study, which had a head-on comparison with gemcitabine, which really led to unprecedented increase in survival from 6 months to almost doubling to around 11.5 months. And then we had some, but this particular protocol was difficult to institute in most of the patients. It was quite toxic. And then came a weekly regime of combination of gemcitabine and nab-Paclitaxel, and which again had a survival benefit. So looking more deeper into the data that we have, so FOLFIRINOX versus gemcitabine was a randomized controlled trial. It was published in New England Journal of Medicine in 2011. It was the first time that such a steep or such a remarkable increase in median overall survival was witnessed from 6 months to almost 11.5 months and 11.8 months, almost doubling of the median overall survival with a protocol like FOLFIRINOX, where triple drug was used. And so the inclusion criteria was that the patient should have a good performance status and a very normal liver function test. And we know that a large number of patients of metastatic CA pancreas will have obstructive jaundice and will require stenting. So this could be one of the offending factors for using a protocol like FOLFIRINOX. Also, there was one important endpoint of EORTC quality of life, C30, global health status and deterioration of more than 20 points, which was more severe with gemcitabine as compared to FOLFIRINOX. So FOLFIRINOX was definitely maintaining the quality of life for a longer duration of time, despite its toxicities. The other study was the nab-Paclitaxel gemcitabine study, again a head-on comparison of a large number of patients, more than 1,000 patients, which were randomized 1:1 to gemcitabine versus nab-Paclitaxel and gemcitabine. Over here, nab-Paclitaxel was instituted before gemcitabine, and the theory behind this was that nab-Paclitaxel gets preferentially concentrated into the tumor milieu or the tumor microenvironment through the spark protein. And as nab-Paclitaxel enters into the cells, it may act as an inhibitor of cytidine deaminase, which metabolizes gemcitabine, and hence increasing the gemcitabine intracellular concentration and bringing in higher responses to gemcitabine. So there was some biological basis of having a combination like this, nab-Paclitaxel followed by gemcitabine in this particular protocol, and it was named as the MPACT trial. And again, it was a New England Journal of Medicine 2 years later after the FOLFIRINOX study. The study met its primary endpoint of median progression-free, the primary endpoint of median overall survival, which increased from 6.7 months to 8.5 months. So numerically, it is lesser, but it has an impressive hazard ratio. If you look at the hazard ratio of the FOLFIRINOX study, it was 0.57. So it is definitely better off. The FOLFIRINOX is definitely better off, not only numerically, as in terms of hazard ratio, also it is better off. So one would definitely prefer to have FOLFIRINOX. Now, since we have also seen the data coming from the adjuvant studies of these particular two regimes, it appears that FOLFIRINOX does slightly better than as compared to nab-Paclitaxel gemcitabine. But this is a cross-trial comparison, and one should not do a cross-trial comparison. Even if we do it, it has to be interpreted with caution. So FOLFIRINOX, the PFS between the two regimes is 5.5 months versus 6.4 months, 8.5 versus 11.1 months. The hazard ratios are favoring FOLFIRINOX, but definitely the toxicity profile can be different. Neuropathies are more common with nab-Paclitaxel, we know that, and fatigue, growth factor support, and febrile neutropenia are more common with FOLFIRINOX. So the major determinants of treatment choice include performance status, age, the liver function test, patient preference, sometimes UGT1A1, because there can be some surprises, pre-existing neuropathy. Many of our patients are diabetic, so we need to take into account the pre-existing neuropathy, the albumin content, the platelet count, and so on and so forth. Of course, deeper responses are registered with combination therapies, and hence it can lead to improvement in survival. And there are various ways by which one can improve survival, such as increasing the cytotoxic power using maintenance therapies. So there is definite role of using maintenance therapies. After FOLFIRINOX, one can use leucovorin 5-FU2 as a maintenance therapy, or Gemcitabine. And after nab-Paclitaxel, Gemcitabine, one can use an alternate type of protocol with lesser doses, or day 1, day 8, every 21 days type protocol, or Gemcitabine alone as maintenance therapies. These are all corroborated in the NCCN guidelines also. So as far as the evolution of frontline regime is concerned, over the next 5 years, it appears that there will be some more agents. However, a very disappointing study was published in the ISMO 2020, which is called as the PA7 study, which combined nab-Paclitaxel Gemcitabine with durvalumab, and the study was a total failure. So the IO drugs doesn't seem to work very well as far as metastatic pancreatic cancer is concerned, unless until somebody is MSI high. So there has been a lot of data about what to use next. So there is some data about once patient has used FOLFIRINOX, and then we go on to use nab-Paclitaxel Gemcitabine, one can expect a response rate in about 17.9%, a partial response. And so there would be definitely some dose reduction more commonly done as compared to patients who receive this upfront. And but a progression-free survival of about time to treatment failure of about 10 to 12 months is expected, and overall survival which has been seen. But it is definitely a very small study. So definitely whatever has been used previously, one has to use something different in the next go. Regarding second line therapies, after one has received any of these upfront therapies, either FOLFIRINOX or nab-Paclitaxel Gemcitabine, one can use a FOLFOX-like protocol versus a 5-FU based protocol. So this is called as a CONCO 003, which randomized patients to addition of oxaliplatin to 5-FU after patient has relapsed after a Gemcitabine based therapy. And they looked at the data which showed that the progression-free survival and overall survival was slightly better with the addition of oxaliplatin after a patient has failed Gemcitabine-based therapy. However, there is another study which is a phase 3 study, a JCO publication. JCO publication, which also tried to answer the same thing, whether addition of oxaliplatin actually results into improvement in progression-free survival. The PFS was better with oxaliplatin, but ironically, the overall survival was poorer because the number of patients receiving post-progression therapies with after leucovorin 5-FU was much higher as compared to those who received oxaliplatin. So the result of these particular studies was not in keeping with the CONCO 003. So it remains very confusing. However, there is another SWOG experience. It shows that definitely using oxaliplatin in the second line after a patient has failed on a Gemcitabine-based protocol does result into increase in progression-free survival and overall survival. And the guidelines also talk about this. MM398, which is nano-liposomal irinotecan, is actually different than the standard irinotecan, and it is increased and prolonged concentration. It basically provides increased and prolonged concentration of irinotecan and active metabolite SN38. And we had the Napoli-1 study, which was a Lancet Oncology publication. It was a phase 3 trial of 400 odd patients and randomized to the nano-liposomal irinotecan with 5-FU versus 5-FU leucovorin alone versus using the same agent as a single agent. And if you look at the results are definitely in favor of nanosomal liposomal irinotecan and 5-FU as compared to 5-FU alone. Whereas monotherapy was not as better. It was almost equal to what one would achieve with leucovorin 5-FU. So definitely a combination of nano-liposomal irinotecan plus 5-FU and leucovorin seems to have a much better progression-free survival and overall survival. So these are the curves. So definitely this is one of the treatment options, but I think it is quite costly and is not routinely used in clinical practice, but this is definitely one of the agents which can be used. The toxicities with this protocol are febrile neutropenia seen in 1.7%, neutropenia in 27%. Of course, we know that diarrhea can be a problem with irinotecan, so that is seen more evidently with this particular combination. So this is how one would sequence the various available agents. After GemNab, one can use modified FOLFOX as per the Conco 003, or if somebody has access to nanoliposomal irinotecan with 5-FU, that can be a treatment option, or capecitabine alone. If FOLFIRINOX has been used, one can go ahead with Gem and nab-Paclitaxel or gemcitabine as a single agent, or in fact use irinotecan with leucovorin 5-FU as a treatment modality. There's, just for completion, not that it is approved, sunitinib has been used in a randomized phase 2 data which showed that there can be some improvement in overall survival and progression-free survival as a maintenance strategy. It is not yet approved. There are various potential biomarkers. None are routinely used. And of course, the discussion cannot end before we talk about PARP inhibitors and the knowledge of BRCA1 and 2 mutations, or the HRD mutations. And we know that those patients who have germline mutations, they do better with platinum, and the guidelines do talk about that such patients should be treated either with gemcitabine cisplatin upfront or a FOLFIRINOX, which has a platinum agent, whereas other patients should be treated with either GemNab or a FOLFIRINOX combination. 1 in 15 patient can have a germline mutation in pancreatic cancer, and so the ratio of BRCA1 versus BRCA2 is 1:3. So BRCA2 mutation is much more common in these population. And we had the POLO trial, which was presented and was published in New England Journal of Medicine, which randomized these patients in 3:2 fashion to olaparib versus placebo, with PFS as a primary endpoint and multiple secondary endpoints. So the progression-free survival was improved from 3.8 months to 7.4 months, and the median progression-free survival was practically doubled with a very impressive hazard ratio. Not only this, there were more responses in the olaparib arm, and more patients had a stabler disease. So overall disease control rate was better than as compared to placebo. The overall survival didn't look very different, but it was 19 months as against 19.2 months, whereas the time to first subsequent anti-cancer therapy was definitely increased, and the PFS2 was also increased. It was 16.9 months versus 9.3 months, and 9 months versus 5.4 months. So all these very important subsequent endpoints, and we keep seeing these endpoints in olaparib-led studies. These are the swimmers plot, which show that a significant number of patients have an overall survival in excess of 2 years. The toxicity profile is very well known to all of us. And to conclude, olaparib maintenance following a platinum therapy significantly improves progression-free survival in patients who have germline BRCA mutation. At 3 years, about 17% patients remained on olaparib as compared to 3.3%, and 21.5% of patients on olaparib remained free of subsequent cancer therapies versus 3.6%. And 33.9% of patients receiving olaparib were alive compared with 17.8%. So the overall, although the overall survival did not demonstrate a statistically significant difference, but I think the totality of the evidence does support the use of olaparib in patients who have germline BRCA mutation. I'm yet to find any patient of germline BRCA mutation in pancreatic cancer, although we have started doing it quite routinely. Coming to periampullary tumors, it basically defines those tumors which are arising either from the head of the pancreas or the duodenum. And the topography is important, but I think it becomes, once patient comes with an advanced disease, it becomes very difficult to understand whether it is coming from the ampulla or it is coming from the pancreas. But this differentiation is important. Simply put, about 22% to 50% would be coming from as duodenal carcinomas, whereas ampullary carcinomas, pure ampullary carcinomas, would be around 30%, and another 30% would be distal cholangio or pancreatic adenocarcinomas. So it is important. I think this differentiation can be made on immunohistochemistry, and usually those who have intestinal origin of this particular tumors are treated mostly with the 5-FU based therapy, then a gemcitabine based therapy, and this differentiation is important. but more or less the guidelines of treatment remain same, and it remains a palliative treatment. There's lack of phase 3 data to discuss, or real evidence-based literature is lacking. But as far as intestinal cancers are concerned, be it duodenal origin, they are generally treated more like colon cancers or large intestine cancers, and the treatment guidelines are more like colon cancer of small intestine carcinomas as compared to treating them like pancreatic tumors. So FOLFOX may be a preferred treatment option. And I think I can stop here. Thank you very much, and back to the organizers.
Yeah, thank you, Dr. Manish, and thank you for sticking with time. It was a very brief and concise presentation. So, like being a surgeon, I wouldn't be able to ask you questions regarding metastatic, but then we often encounter this situation in adjuvant setting where we have a tumor and we aren't sure about the origin of the tumor. So, how do you go about in that scenario?
So as far as resectability is concerned, if it is a resectable tumor, you will go ahead and resect it still.
Adjuvant setting after resection.
Adjuvant setting means after the resection has been done, and we don't know what is the epicenter of the tumor. I would definitely ask for an immunohistochemistry and very specifically ask the pathologist whether it is an intestinal tumor or whether it is a pancreatic tumor. But as far as the adjuvant setting is concerned, we know that we have the SPAC data, which shows that 5-FU versus gemcitabine, only the toxicity differed, and the survivability did not differ between gemcitabine and 5-FU in the adjuvant setting. I would be more prompted to use a FOLFOX regime for this patient rather than using a gemcitabine based regime if the confusion prevails. If the confusion prevails, I definitely use FOLFOX or 5-FU based regimes, because we have randomized phase 3 data of gemcitabine versus 5-FU where the median overall survival was same, only the toxicity was different.
Yeah, I think that answers my question. And Dr. Fali, you want to add something?
No, I mean, as expected, Dr. Singhal very elaborately every time dissects trial and give us the crux. So yeah, I mean, nothing much to add on or comment on. So I think we should move on to the panel and take the questions as they are posted.
So with that,
as told earlier, I have to join another meeting.
Yeah.
So please pardon me.
Thank you so much for taking out time. Yeah.
Thank you.
We'll not force you to stay back. Thank you.
Bye.
So with that, I would request Dr. Rajat Saha to take over and start the panel discussion.
Thank you. Thank you very much, Dr. Nikhil and Dr. Shefali. And the overall the treatment of let me share my screen and then I'll continue to talk.
Rajat, I am the only surgeon here, so if you have any question, then you can throw that at me. We haven't kept a surgeon in the audience because this was going to be mostly metastatic and unresectable setting.
Yes, I understand. Fair enough. So thank you, Dr. Nikhil, for pitching in as our lone surgeon in this metastatic carcinoma pancreas program. Dr. Shefali had asked me to moderate a session on the metastatic setting. So I have generally kept that kind of a setting only, and I've limited my discussion to that only. So that was a very enlightening talk by Dr. Manish, very concise, and he has actually covered a lot of things and has made my panel discussion pretty easy. So Dr. Arvind, is he there from Buddha Cancer Center? Dr. Arvind?
I'm there, sir. I'm there.
Fantastic. Welcome, Dr. Arvind.
Yes, sir.
And Dr. Rashi is there. Dr. Viraj is there. Okay, so and Dr. Shefali, you're always there, and Dr. Nikhil, you're there as one of our expert surgeons. So let me begin. Basically, I would like to kind of base my panel discussion on these questions which we need to answer as regards the real life case scenarios and as regards what our medical oncologists would do in or radiation oncologists would do in this situation. So first and foremost, we'll be discussing on the locally advanced but unresectable carcinoma pancreas. Second, we'll also then we'll go on to the purely metastatic cancers, whereby we'll discuss the first line, second line, and the newer advances. So, Dr. Nikhil, uh, you are the surgeon, and obviously you would be most interested in this question as to which imaging would you consider to be ideal for the diagnosis of pancreatic cancer?
Yeah, so I would want a pancreatic protocol CT scan, thin cut, right? So I want a slices with 5 mm, I mean, sorry, less than 5 mm, so
Yes,
around 1 mm slices, and a triple phase CT, a pancreatic protocol CT.
Perfect, perfect. So what you are you're absolutely correct is that generally our patients walk in with a dual phase CT scan, which has been done for different centers. So that is currently not the ideal way to actually get the maximum information on the anatomical extent as well as the vascular extent of the tumor. So it has been said that in various studies, the triple phase pancreatic protocol CT scan gives additional 56% more information as compared to a dual phase CT scan. So definitely this is what we need. We need a good arterial phase and a portovenous phase. And as Dr. Nikhil has mentioned, we need a very thin slice reconstruction, preferably approximately 1 mm reconstruction, which is very, very important for our surgeons to actually know the vascular anatomy of the tumor and the vessels basically. The role of MRI abdomen, Dr. Nikhil, you would
Uh,
also go ahead with the MRI or an MRCP over and above the
Not
triple
really.
phase?
No.
Okay. So MRI would just be limited to those patients whereby a CT scan is contraindicated, it's like a waist creat or something. But otherwise, do you think that an MRI is a triple phase MRI is better as compared to a triple phase CT for diagnosing some small hepatic mets or something?
Not really. So that is in the setting of colorectal cancer, liver metastasis, post neoadjuvant chemo, and HCCs. But there is, as far as I know, there is no data that MRI will give us a little more metastatic disease than a good quality triple phase CT. So I would be okay with just a triple phase CT scan, and that's it.
Mhm. Correct, correct. And Dr. Arvind, what is the role of PET scans? Are you doing PET scans in your routine practice?
No, sir. Yeah. In my routine practice in pancreatic cancer, generally I don't do. Means CT chest abdomen is okay, but sometimes if considering that it is a profuse means profusely metastatic disease, then only I go for PET scan upfront.
Mhm. Exactly. So that is an excellent observation because in the real life, basically, we generally do not require a PET CT scan. But if the resources are available, we generally get it done. At least in Delhi, a lot of patients actually insist on PET CT scan, and we definitely do it for extra pancreatic disease. So this is as regards the imaging. So ideal imaging is a triple phase CT scan or a CT scan with a pancreatic protocol. And what we are actually trying to see is the various arterial. Dr. Nikhil, for the benefit of our audience, if you could just tell me the SMA, SMV, celiac axis, what all arteries or venous systems are you looking at?
So pancreas is a very critically placed organ, right? So there are two important vessels which course through it. So portal vein, so SMV, and SMV is joined by splenic vein and becomes a portal vein. So that actually courses through the head of the pancreas, right? And then there is SMA, which comes from behind the pancreas and then goes on to supply the small intestine, right? So that is superior mesenteric artery. And on top of pancreas comes the branches of celiac axis. So there is a common hepatic artery, which uh, courses over the pancreas. The common hepatic artery goes up. supplies the liver, bifurcates into right and left, and just at the neck of the pancreas, it adopts a branch called GDA, right? Gastroduodenal artery. So these are the artery which are relevant in terms of head of pancreas. When we're talking about body of pancreas and tail of pancreas, then there are more vessels. One is celiac axis, right? So that is important there. And then there is splenic artery and splenic vein. So splenic artery and vein we aren't much worried about because we can always sacrifice the spleen if they are involved. Celiac axis definitely we are worried about. Common hepatic artery we are definitely worried about. Portal vein we are worried about, but then that is for preoperative planning because portal vein is generally not a contraindication for surgery. We can reconstruct, but that will classify the patient as borderline resectable, and SMA involvement is considered unresectable.
Correct. So venous reconstructions are still possible. That means if you have a complete effacement of the venous SMV or the portal vein, you mean to say that you would be still be able to do a venous reconstruction, but a SMA greater than 180 degrees abutment would definitely render the patient unresectable. As correctly said, this is the recent NCCN guidelines which are saying the same thing, and what we are looking at is the encasement more than 180 degrees of an artery, so that renders the patient unresectable. So doctor, basically now coming to the management of these unresectable locally advanced, these are not metastatic but locally advanced pancreatic cancers. Obviously, when our in our multidisciplinary tumor board, when our surgeon has rendered the patient unresectable, then let Dr. Arvind and Dr. Rashi can plan the treatment. So, Dr. Rashi, what do you think should be the further management of this patient?
Yeah, Dr. Rajat. For unresectable pancreatic cancer, that means the disease is limited towards the pancreas, but it is unresectable due to involvement of vessels. Actually, at this moment, when the disease is limited to pancreas, the radiation therapy can be done for palliative purpose, but it is seen there are some occult metastatic disease that is not visible when we do some scans, and it maybe appear. So it is, I think it is a good idea if we start from chemotherapy and see if the patient is responding and the disease is limited to at the local site till the end of therapy. And if it is not metastatic at that time we can add radiotherapy.
Dr. Arvind, do you agree with this?
Yes, sir. Generally, means in this scenario, I go for combination chemotherapy in these cases, sir.
Correct. And Dr. Shefali, which kind of chemotherapy would you prefer? We have two standard frontline chemotherapy options. We have got Gem-nab-Paclitaxel and we have got FOLFIRINOX. Dr. Shefali, you there? She's not there. Then Dr. Arvind, which chemotherapy would you use?
Young patient performance status up to 2, even up to 2, I go for FOLFIRINOX. Otherwise, nab-Paclitaxel and Gemcitabine.
Okay, good. So I think so. Both our radiation oncologist and medical oncologist concur to the fact that in this management, first of all, we need to start with chemotherapy. Give 4 to 5 months of induction chemotherapy, then judge the biological behavior, judge the metastatic potential, again do a re-imaging, and then if the patient is not metastatic, then definitely go in for radiation therapy. You would, Dr. Rashi, you would prefer only radiation, or you would prefer a concurrent chemo and a radiation at the end of induction chemotherapy?
Yeah, actually at that time I'll see the size of disease. Okay, so I was thinking about stereotactic radiotherapy. You know, if I could do stereotactic radiotherapy, I will see the invasion of duodenum and the location of the tumor. If I could do stereotactic body radiotherapy, SBRT, so I would like to start that treatment. And in SBRT, we don't require actually concurrent chemo at that time. And if because of any reason I am not able to do SBRT and I am doing conventional radiotherapy, then at that time I think it is better to give concurrent chemo.
For the benefit of our audience, means what are the benefits or the pros and cons of conventional vis-a-vis SBRT?
Yeah, yeah, sure.
Is the disease control better with SBRT, or is it just the time factor key? The time taken is less for SBRT and the time taken for conventional?
Yeah, actually, time taken is definitely less. Usually, SBRT completes if it's a 5-fraction treatment. Okay, so it takes about 1.5 weeks. And when we talk about conventional, it goes around 5.5 weeks. So definitely, time is one of that point. But second is what we see with SBRT, we are able to give higher dose. Okay, when we plan in GI, in pancreas, there are so many nearby structures, they are critical. So we have to manage dose to these normal structures. So there is a limit of dose. We cannot go beyond that dose. But when we are doing this SBRT, so we can give more dose. So the literature also says, according to, we have seen in other sites also, with SBRT, control is better. Okay. So we have extrapolated that data here also. So I was actually just seeing in National Cancer Database study, when we do SBRT, so median overall survival is better. It is about 13.9 months in comparison to conventional chemoradiotherapy. It is 11.6 months. So,
okay, so that is the difference, at least in one study. Okay. Yeah. So definitely then, if the facilities are available, you and the size is lesser, is there any size cutoff for you to start SBRT?
No. Not, yes. Actually, what we prefer up to 4 to 5 centimeter. That we prefer. If the tumor is 7, 8, 9 centimeter, then we have to actually increase the fractions. We cannot do in 5 fractions. We have to limit the dose 10 fractions or 15 fractions. We don't go for 25, 28 fractions. Okay. So we have to modify accordingly. But the important thing is to see the invasion of duodenum. So if the duodenum is invaded, stomach is nearby, then we have to see the dose to these structures. Okay. Mm-hmm. So, yeah. So then we have to decide either we can do SBRT or we have to go for conventional if these structures are involved.
Mm-hmm. Dr. Nikhil, another very common scenario is on initial imaging. You thought that definitely the patient would be resectable, but you went in and you found the patient inoperable on table. So that is also a scenario which is seen. So in that event, would you just open and shut the patient, or would you go for a palliative gastrojejunostomy or a triple bypass or anything you would just do?
So generally, I wouldn't go for anything. In case, because generally these patients would have presented with obstructive jaundice, and the option for them would be a metallic stenting. But if I know beforehand that there are financial constraints or something where the patient wouldn't be able to go for metallic stenting, then I might do a bypass in those patients with a gastrojejunostomy. But generally, we would have taken a resectable patient. So it means that there wouldn't be in an advanced stage of malignancy where a gastrojejunostomy would not be required, and we will not do HJ because it will interfere with their further treatment and all that. So we'll just close it.
Okay, fair enough. Okay. So as told by my consultants, definitely the treatment of choice in a unresectable locally advanced disease starts with induction chemotherapy, preferably 4 to 6 months, followed by chemo radiation. Dr. Arvind, just in short, which chemo partner generally do you choose with your radiation therapy in concurrent for pancreas?
Generally Gemcitabine, sir.
Low dose Gemcitabine is what you prefer.
Yeah, okay. Yeah.
And or capecitabine also we generally
capecitabine sometime, but mostly I have used Gemcitabine, sir, along with radiation.
Gemcitabine is a very potent radiosensitizer. Yes, low dose Gemcitabine can definitely be given. Rashi, you're comfortable with Gemcitabine as the concurrent partner?
Yeah, I'm comfortable.
Yeah. So this is about the management of a unresectable carcinoma pancreas. And this is what I asked Dr. Nikhil also, whether you would like to consider gastrojejunectomy or not. And he correctly told that if it is not clinically indicated, then definitely you will just open and shut, and thereafter refer the patient to the medical and the radiation oncologists. Okay. So now let us put a case, and let us try to dissect out the various nuances of treatment in metastatic pancreatic cancer. So we had a 63-year-old male who had a recent onset diabetes, and he presented with complaints of epigastric discomfort radiating to the back, and approximately 4 to 5 months duration, and a weight loss of approximately 5 kgs in the same 4 to 5 months. So, and he also had loss of appetite. So overall, very typical presentation of a carcinoma, pancreatic carcinoma is there. And this was the initial CT scan which was there. And definitely here we can see, Dr. Arvind, if you can comment on the CT scan.
So there is a means a growth in the
Head of pancreas.
head of the pancreas with multiple liver mets.
Correct.
And in this scan, nodes, there are nodes also means near the IBC, but I'm not sure about the nodes. But definitely there is a head of the pancreas mass with liver mets.
Correct. So this is a very common presentation, Dr. Arvind. You would agree, for a metastatic carcinoma pancreas, and the biopsy was basically a poorly differentiated adenocarcinoma. Biopsy was taken from the liver because of the ease of doing a biopsy. Otherwise, generally pancreas is not very easily accessible, and you have to go in through an EUS guided FNAC and a cell block. So a biopsy was done from the liver, and it was poorly differentiated adenocarcinoma, and a CA 19.9 was done as a marker, which was 1244 units, and CEA was done, which was 3.5 nanogram per ml. So this was the initial presentation of our patient. And basically, I think so, Dr. Arvind, you are the only medical oncologist in the panel. Dr. Shefali, if she's there, she can pitch in. So
Dr. Rajat, Dr. Viraj is also there on the panel.
Oh, Dr. Viraj is there. Oh, I've totally ignored Dr. Viraj. I'm very sorry, Dr. Viraj. So okay, good, very good. So Dr. Viraj, so this is a metastatic carcinoma pancreas. So what is the initial choice of? He's a 63-year-old male, recent onset diabetes.
Yeah, so like Dr. Arvind said, the performance status 0-1, I tend to go with pump and FOLFIRINOX regimen. But if patient is, let's say, borderline performance status, and we discuss with the family that what are their goals. Do they want the pump? Do they want the port placement? Then we go with nab-Paclitaxel.
Okay. So apart from the PS, any other thing which will prompt you towards FOLFIRINOX or towards nab-Pacli? You think any one of these treatment is better than the other?
So we have evidence, retrospective evidence, that FOLFIRINOX may have an edge over nab-Paclitaxel, although there is no randomized head-to-head trial. But we know now that if a patient has BRCA mutation alterations, then probably platinum-based regimen may edge over. We have recently started doing BRCA on day one for all patients. And like Dr. Manish was saying, I too have just 2 patients found so far. It's the incidence is just 4 to 5%, I think. So it's not very promising biomarker. I think we need more. So until that time, I think so it's just personal preference.
Correct. So Dr. Arvind, your choice of treatment?
Yeah, I agree with Dr. Viraj. It all depends upon the performance status. But upfront, I generally prefer 3-drug regime in my patients.
So, Dr. Viraj, if you can just forget this patient, let's say in the last 50 or 60 patients which you have treated in the last few years of pancreatic cancer, you have tilted more towards, in the real life clinics, you have tilted more in towards the nab-Pacli, keeping in mind the performance status, the economic standards, everything. What is, I just want to know what the oncologists in India are treating more with, nab-Pacli or FOLFIRINOX?
Right. So if you see my last 50 patients, we do see about 50 patients a year of pancreatic cancer since we are doing only GI. So predominantly, I would agree with you, 80% would go with Gem-nab-Paclitaxel because the hassle of port is somehow not very well taken by patients. So, and we have new data of Gem-nab-Paclitaxel 2 weekly from Mayo. And eventually all of my patients after second or third months eventually go up with day 1, day 15 rather than day 1, 8, 15. And there are so many patients who are going beyond 9 months plus, and they just come twice a month and take their shots and survive. So I think so in my practice, Gem-nab is prevailing more.
Correct. So that is a very interesting point which you have raised, this Mayo Clinic regimen, because earlier we used to use the day 1, 8, 15 Gem-nab-Pacli, which used to create a lot of neuropathy and it used to create a lot of fatigue in our patients. So this 2 weekly protocol is definitely pretty friendly for our patients, and the patient and they would be able to take a longer duration of treatment. So that is a very good alternative.
Can I just say one word?
Yeah, Arvind.
If you are talking about real world practice, sometime in my patients who are not so affordable to go for FOLFIRINOX, because in that case intensive means admission is required. I sometimes add Gemcis nab-Paclitaxel, and few of the patients are doing well, though we don't have any hard data about this. But extrapolating from the GV malignancy, I sometimes use in pancreatic also.
So Gemcis and nab-Pacli.
Nab-Paclitaxel, day 1, day 8.
No, you're using 3 drugs: Gemcitabine, cisplatin, and nab-Paclitaxel.
Nab-Paclitaxel, day 1, day 8, 21 days regime.
Okay. Good. So this is actually the list which it all started with single agent 5-FU, then Gemcitabine, then Gem-nab-Pacli, Gem-cap, Gemcis is there, Gem-erlotinib is there. It is I personally do not prefer that regimen. It doesn't give anything. Fixed dose rate Gemcitabine is there. Triple drug Gemcitabine combinations are there. FOLFIRINOX and definitely the modified FOLFIRINOX. So Dr. Viraj, what dose of FOLFIRINOX are you comfortable with in your practice? How much have you modified the dose?
So my modified version of FOLFIRINOX versus the literature for modified FOLFIRINOX are slightly different,
Yes.
especially after the COVID. So the differences are especially in the irinotecan dose. I tend to use at 135 per meter square rather than 150, what is mentioned. I always omit the bolus, and now onwards I've also started to omit the leucovorin, because the leucovorin is for the bolus 5-FU, not for infusional 5-FU. So it's essentially oxaliplatin, irinotecan at 135. Even oxaliplatin, I go down to 65 per meter square rather than 85. And then 5-FU, we try and maintain the dose. So that's my version of FOLFIRINOX. And I never admit patients for FOLFIRINOX. It's always pump treatment at home. Because 48 hours of hospitalization for a metastatic pancreatic cancer, they don't like to stay in hospital, like 4 days out of a month. So only if they want a port placement, then only I go for FOLFIRINOX.
And in your practice, do you routinely use any PEG GCSF or a conventional GCSF along with your modified FOLFIRINOX, or do you think the patients don't need PEG GCSF or GCSF?
I used to do it, but then once I developed these dosages, I think so, 65 oxaliplatin, 135 irinotecan, I don't think so these patients require, because I did try it on my own, and I think so they are usually fine without GCSF.
Okay, good. I think so the light has gone off on my end. So let's proceed ahead. So overall, these are various papers from the Korean database, which they have compared FOLFIRINOX versus Gem-nab-Pacli, and this is another paper which is again comparing FOLFIRINOX versus Gem-nab-Pacli, and so overall, definitely in terms of response rates, in terms of overall survival, in terms of progression-free survival, my medical oncologist would concur in that there is no major difference in the FOLFIRINOX versus Gem-nab-Pacli. Yes, Now we definitely base our treatment on the performance status, on the age. A good performance status in a younger age population would definitely be preferable to use the modified FOLFIRINOX. And definitely, as Dr. Viraj and Dr. Arvind have told previously, now we have one biomarker. It is a weak biomarker, but still a biomarker. We generally do the BRCA status, and then we may try to tailor our treatment. So, okay. So, a practical question, Dr. Arvind.
Yeah.
You see the patient on day one, and you send the BRCA status. The BRCA status generally takes about 20 to 25 days to come. What do you start the patient on? You start the patient on Gem-nab-Pacli. Suppose you start the patient on Gem-nab-Pacli, and after 20 days the BRCA status comes out to be positive. Are you prompted to change the treatment line to Gemcis, or do you plan to continue with Gem-nab-Pacli?
No, if the patient comes BRCA positive and the patient is responding on GemNab, I don't change my treatment plan. If any patient responding on any regime in a palliative setting, the dictum is you should not change that regime till the patient is responding. Okay. And this is also the caveat of that trial, the POLO trial, that those patients who were responding and they were all of a sudden taken off from the trial and they were put on olaparib, if I remember. Yes, so I think that any patient who is responding on any of the regime XYZ in any metastatic palliative setting, that regime should be, we should extract the benefit as much possible from that regime.
Mm-hmm. Dr. Viraj, anything you would like to add in this real life case scenario? Suppose.
No. So I'm still waiting.
Continue.
So I'm waiting for this thing to happen to me yet. But if I have started Gem-nab-Paclitaxel, certainly I would be tempted to do Gemcitabine if the report were to come within 2 weeks or 3 weeks time. Because by that time, we still don't know whether this patient is going to respond or not. But I completely agree with Dr. Arvind. If the patient is already doing well, I would reserve it for subsequent lines and not change.
Correct. So now this, as we all know, and then the POLO trial, it has been popularized quite often that approximately 5 to 7%, or maybe even less, a percentage of our patients are BRCA germline mutation positive. Now, what the people in US are doing is basically they are checking for the DNA damage repair pathway rather than only the BRCA. BRCA is just one component of the homologous recombination pathway. So they have found out that the pancreatic ductal adenocarcinomas, up to 17% of the pancreatic ductal carcinomas harbor the DNA damage repair pathway defects. So these are those 17. So ultimately we have increased our percentage from 5% to 17%, and these 17% may definitely prompt us to use a platinum-based regimen rather than a non-platinum-based regimen. There is no prognostic difference between the patients with the DNA damage repair positive versus negative, but yes, it has a predictive effect that we may tempt to use the platinum-based regimen, either cisplatinum or oxaliplatinum. So, coming to the second line therapy, now I think so Dr. Viraj and Dr. Arvind would agree with me that in pancreatic cancer is one of the cancers where the patients have one of the most dismal rates of going on to the second line therapy. And this is second only to glioblastoma. So these are the two cancers where patients generally 60-70% dropout is there from first line to second line. Do you agree, Dr. Viraj, in your clinical practice?
Absolutely. So especially when we have done Gem-nab-Paclitaxel first, telling them that you need a port and a FOLFIRINOX, subsequent line, they said, okay, enough. So all of my subsequent line patients are the ones whom I have started FOLFIRINOX and then have been shifted to Gem-nab-Paclitaxel. So I completely agree. It's a very poor second line uptake in these patients.
Correct. Dr. Arvind, how many of your patients are you able to prompt to a second line therapy? कितने लोगों को आप convince करके दे पाते हैं actually?
Sir, if I remember, I think I remember just one or two patients in my practice till now who were on second line, and means just by chance or whatsoever you say, one of my patient on erlotinib, she continued it for 1.5 years before she finally the disease progressed. But maybe the disease biology was somewhat, and another patient who has been who is presently doing very good. Later on, when we reviewed, it was means with neuroendocrine differentiation. The pathologist they can't comment on the exact percentage of the neuroendocrine component, but this patient he is means metastatic pancreatic cancer with neuroendocrine differentiation and doing quite good on second line.
Okay, what second line are you giving him?
Hello.
Which second line are you giving? Are you going towards a irinotecan or a etoposide cisplatin carboplatin kind of a thing?
I am giving him cis etoposide.
Okay. Fair enough. Good. So these are the very lucky few who are kind of doing very well on the second line.
Just for two of my patients in last 5-6 years of practice.
Correct. So that is a very dismal rate, and obviously, again, when we have very good frontline agents, we just have to kind of interchange the regimens and try to give the second line regimens. These are some studies which have tried FOLFIRINOX after gemcitabine based therapy. It is definitely a difficult task for us to convince our patients, and there are certain the other way around also means we can use gemcitabine nab-Paclitaxel following FOLFIRINOX, or we can use FOLFIRINOX following gemcitabine nab-Paclitaxel. And here again, I would like to reiterate the method adopted by Dr. Viraj is that 2 weekly gemcitabine nab-Paclitaxel in the second line is very well tolerated. It gives lesser incidence of neuropathy, lesser incidence of neutropenia, and definitely would be a valuable second line treatment option post FOLFIRINOX. So Dr. Manish had highlighted the newer second line options. One is a nanosomal irinotecan. Obviously, none of us have any first line experience with nanosomal irinotecan, but we are very excited to get this molecule. And definitely a very, very minuscule percentage of patients, at least I would say theoretical, because I have not found any of MSI high in pancreatic cancers. Dr. Viraj and Dr. Arvind, have you found any MSI high in pancreas?
So I have one patient, and she did not do well on Pembro. Even the data of MSI high pancreatic cancer, the response rate is again the most dismal out of all other MSI tumors. So it's less than 50% response with Pembro, and the incidence is less than 1%. So when I was reading, I used to jump out of chair, but now I think so. My institute, we have done around 40 testing at least for last 1 year, and so far we found one. I think so that was a lucky find, but even that she just progressed right at second month. So my enthusiasm have toned down for MSI in pancreatic cancer.
Correct. Dr. Arvind, any experience with MSI? Do you do MSI?
Yeah, I do routinely. It means I am desperate of doing MSI in all the metastatic, all the tumors. I'm means I haven't found any MSI high tumors.
Correct. So now whom do we test for BRCA mutation amongst all? Do you test for all pancreatic cancer patients, or do you ask for a family history and do the BRCA? How is it like?
No, I attempt to do for all the patients, metastatic setting.
Correct. And Dr. Viraj, same for you?
Yes, all patients. And patients who would go to subsequent lines, then I also test for DNA repair and somatic version of these DNA. Because if you take even somatic alterations, the number is as high as 25%. What was mentioned by Pishivian, which is 17%. But if you take somatic versions also, the number is almost 1/4. But only if they make it till the subsequent lines, not in the first line.
Correct. So as correctly pointed out, the teaching from this is that BRCA testing has to be done for all metastatic pancreatic cancers at initial presentation. There is no thing to choose between whom to do or whom not to do, and so this is the way to do it. And say 1, 2, we have got other germline mutations which are there, like CDKN2A, which is the second most prevalent. We have got the MMR for Lynch syndrome, ATM, PALB2 is there, STK11 is there, and TP53. So these are the various germline mutations which are there. And as Dr. Viraj has pointed out, that when the patient actually progresses towards second line, it is worthwhile to do an NGS on the tissue blocks to actually find out various other rare mutations, NTRK or any other actionable mutations, or any other homologous recombinant pathway mutations. Dr. Viraj and Dr. Nikhil and Dr. Arvind, they would agree that there is no major role of immuno-oncology in pancreatic adenocarcinomas, because pancreatic adenocarcinoma is one of the few areas where it is an immune desert. There is generally no T cells in the pancreatic cancer bed, and so the immune oncology drugs generally don't work so well there. So another important association of diabetes and pancreatic cancer. Dr. Viraj, your comments on diabetes and pancreatic cancer.
So I think so. This is very common issue. New onset, as well as in my practice, what I have seen is patients do take diabetes for a couple of years preceding the diagnosis of pancreatic cancer. Even that is very common, I see. And management of it becomes a hassle because the OHs don't seem to work well, especially on the chemo. The sugars keep flipping up and down. So it's a art, I think so, to manage, because we'll need a diabetologist to use insulin, because I don't do that in my practice.
Correct.
So I think this is very important clinical practice issue for managing pancreatic patients.
Correct. So basically, a new onset diabetes is a very red herring for upcoming pancreatic cancer, especially if a patient who's maybe 60 plus and has recently got diabetes. So that is a very and I think so. We don't have any screening guidelines or anything, but these patients should be really followed up in clinical practice for new onset pancreatic cancers. And do we have any maintenance options apart from olaparib? We all know that olaparib is one of the maintenance options which has been highlighted in the POLO trial. Any other maintenance options which you use? Anything from your clinical practice? Do you use single agent gemcitabine? Do you use erlotinib? What do you prefer, Dr. Viraj?
So again, if we have started FOLFIRINOX, I just omit the oxaliplatin. Try to continue at least till 8, but then go on. I like highest I've done is 18 cycles of FOLFIRINOX. I think so it was a lucky patient. But FOLFIRI is always, I don't, because the moment you stop the treatment active agents, within just few months they pop. The CA19-9 starts shooting back. You know, the abdomen pain, backache starts coming back. So I like to continue FOLFIRI if I have started FOLFIRINOX. While on nab-Paclitaxel, like I told you, 2 weekly is a very comfortable regimen. So usually after second or third month, majority of patients that I can remember right now are on 2 weekly. Only for first 2 months, they come day 1, 8, 15 when I want a good response initially. And then they are on and on. And you know, I also try, I don't use the full nab-Pacli dose of 100 or 125 per meter square. I do flat 100. And with that, the neuropathy issue is very manageable. So, but no capecitabine, no treatment holidays, unless patient wants it. But from my side, it's always continuation of treatment.
Correct. Just one final comment before we end the panel discussion. Dr. Nikhil, what is your take on the CA 19.9 in pancreatic cancer? Would you like to operate upon a patient who is looking to be a kind of a localized pancreatic cancer, but with a very high CA 19.9?
So that's a very controversial aspect. And if we initially look at the borderline criteria as defined by Mayo Clinic in the CARDS paper, they have considered
Dr. Nikhil?
Sorry?
Am
I not audible?
Not audible? Yeah.
So there are few patients in our practice who presented with a CA 19.9 of something around 1,800, 1,200, 2,000, and these patients, though looked resectable on scans, we chose to give them neoadjuvant chemotherapy before surgery. But if you ask me a cutoff, I don't have that number.
Correct. So, Dr. Arvind, any thoughts about rising CH-125 or as a prognostic or as a predictive marker of treatment?
Rising CA 19.9, sir. Hello.
Yeah. CA 19.9 is a prognostic or a predictive marker of treatment. Suppose you are giving chemotherapy, the CA 19.9 is still rising. Would you kind of consider revisiting this patient by doing an early imaging?
Yeah, if the CA 19.9 is rising, then means I will be tempted to do a imaging to look for if there is response or not.
Correct. So I think so. Our time is also up, and I thank Dr. Viraj, Dr. Rashi, Dr. Arvind for taking part in the panel discussion, and thank you very much, Dr. Nikhil, for your expert comments on the surgical aspects. I thank you and Dr. Shefali for giving us this platform to discuss a very important metastatic pancreas, very kind of limited treatment options, but still worth discussing.
Thank you, Dr. Rajat. Actually, it was very enlightening, and even like as a surgeon, I could understand the important nuances of management of metastatic pancreatic cancer. Now, with this, I would like to thank all my panelists and speaker, and we would conclude this session. Next is on periampullary carcinoma. So mainly focusing on surgical and other aspects, because periampullary carcinoma is slightly more nuanced than pancreatic cancer. And specifically considering our population, we see more of periampullary than pancreatic, and I see more of discussion everywhere focusing on pancreatic cancer. So I thought we would highlight the differences in the management of periampullary carcinoma vis-a-vis pancreatic cancer. So next webisode will focus on periampullary cancers. So join us, and thank you very much. Dr. Shefali is also there back in action.
Thank you everyone for a very nice discussion. Thank you.
Thank you. Good night.
Yeah, good night everyone. Thank you.